Welcome. We're going to talk psoriatic arthritis in our mid-meeting recap. Joining us is Eric Ruderman from Illinois and Robert Chao from Virginia. Welcome, gentlemen. Robert, you're on mute. You want to unmute yourself? That's going to be good. All right.
That's a good idea.
It's always the best way to begin. All right. Let's quickly ask you, tell me one thing you like, one thing you hate from the meeting so far, this virtual meeting. Make them quick answers. Robert.
One thing I like is I can neither confirm or deny that I'm wearing my pajamas still, pajama pants. And the one thing I hate is I don't get to see my colleagues in person.
All right. Eric.
Yeah, I like the fact that the ACR was nice enough to bring this meeting to my basement for me so I could watch. I actually think that the setup has worked really well. I've been very impressed with the structure of the program and how they put it all together and how you can access everything. That's been pretty easy. I miss seeing people. That's the hard part. I've missed seeing people for 7 months now, and that's the hard part.
Get a dog. That's all we can say.
I got to, and they bark in the middle of the meeting.
A ton of PSA abstracts, I mean, compared to years past. We're midway through the meeting. Rob, what's stuff that you've seen so far that you thought was great at psoriatic arthritis specific wise?
Right. Yeah, so definitely a lot of abstracts on, new therapies and continuation extended study, 52-week extension studies on drugs like, secukinumab as far as sustained improvements in psoriatic arthritis with axial manifestations, guselkumab, a 52-week study, again, sustained response in all major disease domains, improvement in enthesitis and dactylitis. You had rifilgotinib, post hoc analysis with improvement in dactylitis, and also the 52-week extension with improvement on enthesitis. So definitely a lot of new therapies and probably even more coming up.
All right, Eric, what's happened so far? 2 days in, what's the top thing that someone who hasn't been paying so close attention to psoriatic arthritis should go back and look at?
Well, I think the two top things. I mean, in contrast to some of the other meetings the last few years, there hasn't been a ton of sort of new molecules, new stuff. The one exception here are the two upadacitinib presentations, and those data were presented at EULAR. This is the first time they're showing up at ACR. They're both oral abstract presentations, and really good trials on upadacitinib in DMARD failures, and then upadacitinib in biologic DMARD failures, and they set the stage for a kind of a shift in our management of psoriatic arthritis more towards JAK inhibitors in the future.
Have either of you seen anything so far that you're going to take home and change your practice over? Incorporate right away?
Yeah, I mean, I definitely will. I posted a video about this actually, about just adding more tools to our arsenal. That's what I like to say about, especially tailoring treatment to, let's say, an enthesitis predominant patient or dactylitis predominant or skin predominant. But I think one of the big themes this year is definitely enthesitis. We had there was a great lecture by Dr. McGonigal on enthesitis recently. A lot of studies, we just mentioned a few on enthesitis, focusing on enthesitis. There's actually one pretty interesting study that they broke down treatment groups into no treatment / NSAIDs, conventional DMARDs and biologic DMARDs. And they actually found that I think more than 80% of patients had resolution of enthesitis despite the treatment group, which was rather interesting, because that sort of throws up the question, do you even need to treat enthesitis or tailor treatment for enthesitis?
Eric, what about you?
I haven't seen anything I'm going to take home yet, but what Robert brought up is sort of interesting. One of the sort of new studies here is this Achilles study on Achilles tendonitis with treating Achilles tendonitis with secukinumab. It's kind of a mix of psoriatic and SPA patients who had primarily Achilles tendonitis, and they didn't achieve the kind of resolution that they had hoped for. So they missed their primary endpoint. A lot of other outcomes were better, and I think that the abstract, Robert alluded to, is sort of interesting because these people sort of come and go. One of the more challenging pieces of that abstract was that you got into the study by having Achilles tendonitis clinically and on MRI, and yet when the MRIs were read centrally, a little over half of the patients actually had Achilles tendonitis when read by a radiologist centrally. So it brings into the question sort of, what is enthesitis? Is it clinical? Is it imaging? And how do you sort of sort between that? And, how do you, I mean, this is the thing we've struggled with for a while in psoriatic arthritis, is like, how much do you need to treat in those patients?
So Eric, one of the things, it's not solved at this meeting, but there's a lot of data that addresses that. Just between us and the wall and the 135 people online, is axial disease in PSA the same or different than axial SpA?
I don't think we know yet. I mean, I think we keep asking that question. The problem is that there's only one study that really looked at it, and that's this Maximize trial, which there's some data here with the MRIs, and it's a study of secukinumab in psoriatic arthritis patients with axial disease. Everything else we've seen is kind of a sub-analysis of a PSA trial. And again, they said, well, you have axial disease because the investigator at the site said you had axial disease. And yet when they read those images centrally, a lot of them didn't have the changes they said they had. So we don't know what it really means. One of the extracts that I saw that this week that is kind of interesting, it was an abstract that came out of I think it was the Psoriatic Research Consortium, where they looked at a group of patients, some with just basic psoriatic arthritis without axial involvement, some with axial involvement, and they looked at BASDAI scores and whether it could distinguish between the two. Because we think of BASDAI as an axial score, and it was the same in both groups. And the response to therapy was the same in both groups, even including question 2, which asks you about back pain. So it's a challenge to say, I mean, one, we don't know who has axial disease. And then how do we decide if the axial part is better or not? It's a trick one. And it's going to be, and it is a relevant question as we move into the era of IL-23 inhibitors, which don't seem to work for the axial disease, at least in AxSpA.
In AxSpA.
Exactly. And so they looked at that in the guselkumab trials, and it worked, but it worked by virtue of improvement in composite outcomes that may just reflect general improvement. We just don't know.
And with the JAK inhibitors coming, that raises the stakes also. Given
Exactly. Totally.
Rob, what are you thinking? What are your thoughts on that? Is axial involvement in PSA the same as ankylosing spondylitis or axial SpA, or is it different?
Yeah, I think it's a hard question to answer as well. Going back to that Maximize study, though, one interesting thing they did find was a reduction in MRI lesions, which take it for as you will. I think especially guselkumab coming up, interesting to see what the JAK inhibitor data will show too. But it's a hard answer at this point.
Let me put in my 2 cents on this, in that I think it's a good thing it's being addressed. I don't think it's an important question, really, because I'm just looking for a reason to take over management of a psoriatic patient. If it's for their axial symptoms, I'm in. If it's for their peripheral arthritis, whether it's poly or oligoarticular, I'm the guy. It's like I get bothered when I get sent to skin only people and like, why are you here when you should be down the road at Alan Mentor's office, their dermatologist. So Artie alluded to the JAKs are coming on, and they're kind of confusing, or expanding our pretty expanded market in PSA therapy. It's going to get more crowded when we start using TYK2 inhibitors. Eric, what do you think?
Maybe. So one of the late breaking abstracts this time is, let me try see if I can do it right. Deucravacitinib.
Artie, how do you do it?
I think it's a very clever name. I think it's Do You Crave Acitinib?
Oh, there you go. Do you crave acitinib? So and that's the first TYK2 inhibitor we've seen. It's a phase 2 trial of psoriatic arthritis. It worked, but it didn't look like it was much different than anything else. And it's sort of billed as, well, IL-23 signals through the through TYK molecules, and so that's kind of the pathway. The skin response wasn't that fabulous. It certainly didn't look like the kind of skin response we see with some IL-23 inhibitors. The joint response was good, but it wasn't better than we've had. So I don't know that that's going to shake things up. We'll see.
It's coming tomorrow.
Yeah.
Rob, we'll go to you, and then maybe go to Eric for the finale. Stuff that's coming up. I know you have your schedule planned. What you're going to go see tomorrow, and what you're going to go see the rest of the meeting. Well, give us the somebody who said, hey, I want to see what's best in PSA. What should they see in the next couple of days?
Yeah, got it. I think an overarching theme for all diseases, and so in this meeting, just like the last meeting, is machine learning, and you have your gut microbiome. Just like in RA, same goes with PSA. There's going to be a lot of there's an interesting abstract in gut dysbiosis with radiographic and enthesis involvement. Again, tying in that enthesitis theme. A lot of data, even recent or even the past 2 days on machine learning, and there continues to be more machine learning. There is going to be a phase 2b study in tildrakizumab, IL-23 inhibitor, and I believe there's also a late-breaking abstract on TOFA with psoriatic arthritis. And just to tie up with enthesitis again, and having a better way of evaluating enthesitis besides just poking at the Achilles and saying, does it hurt? Yes or no, is there's a
Come on.
Yeah, right. But I can't poke the other 200 enthesis points though. But there's going to be an ultrasound study on enthesitis coming up in the next few days, which would be interesting. Ultrasound scoring study.
Eric, what about you? What somebody interested in PSA who hasn't gone through the booklet yet? What the booklet? Listen to me. In 1980. Who hasn't gone through the program listing online?
Yeah,
what should they go see?
I would, to quote you, I do crave acitinib because I do think that's interesting because it's a new molecule and it's a new, it is a new pathway and it opens up something new. It's an interesting molecule because everything we've seen with JAK inhibitors, there's all these sort of heterodimers and there's sort of the inhibition may cross pathways, and this seems to be fairly specific. Whether that results in anything clinical, we'll see, but I think that's going to be an interesting abstract. There besides that, I'm not sure what else is like earth-shattering. Just a lot of interesting stuff that sort of fills in the holes on sort of extension studies with some of the drugs we've had, fills in some long-term safety data and some of the drugs we've had, sort of some additional sub-analysis of the trials we had to sort of understand in different populations. As I started with, I don't think there's a lot that's earth-shatteringly new in terms of new therapies, but there's just a lot that sort of fills in the blanks with the therapies that we've had so far.
Let me ask both of you, or either of you, research at this meeting about clearing up the issue of what drug is better to use after you failed a TNF inhibitor or more than one TNF inhibitor? Is that an important issue about your next choice of therapy?
It is. I haven't seen much that really helps me there at this meeting, Jack. And maybe you picked something up I missed, but I haven't seen much. I mean, there's, we desperately sort of need head-to-head studies, and we don't have those. We've got 2 head-to-head studies that are TNF versus IL-17. As we move into the JAK space, we're going to need to sort of get some direct studies that say, should you use that's the thing in psoriatic arthritis. We've got all these pathways. We can use an IL-17 inhibitor. We've got IL-23 inhibitors, one approved, more coming. We've got JAK inhibitors that are coming very, very soon. But then we don't know which of those to use, and we're going to need some good comparative data. And I think just taking 2 trials and sort of holding them up against each other doesn't give you the answer you need.
In dermatology, they've got a lot of head-to-head trials, and it seems like it's changed the treatment landscape. Do you think the same will happen in rheumatology?
I hope so, but I don't know. I mean, that's just, for some reason, they've sort of gone down that path, and that's just been sort of the way they've looked at their drugs. I just haven't seen much of that yet. We've got a couple. I mean, what we're going to need is, truly we're going to need is a head-to-head that includes a JAK and a biologic. That's really the next place we need to go. And I don't see anything coming in the near future.
All right, gentlemen, I want to say goodbye. Eric and Robert, thanks for joining the panel discussion on psoriatic arthritis.